These are all the questions that will run in your mind while you look at a failed root canal and you are the dentist who's going to treat it. So let's look at the causes of failure to start with. I showed you this image. What could be the cause? If this patient comes to you, the first thing is, what is the cause of this? How can I do this root canal better than the previous dentist? So it could be poor isolation. Most of us don't even use rubber dam. And my request to everybody is that if you need your root canals to survive for many years, you need to isolate them well. And preferably, it has to be isolated with rubber dam. Poor disinfection. Many of you out there might be using only saline or saline diluted with sodium hypochlorite or sodium hypochlorite diluted with saline, either way. Or there could be a missed canal. Missed canal because of poor vision or poor angulation of the radiograph. So most often, it is the poor disinfection which will lead to failure of the root canal. When I say poor disinfection, missed canal is also poorly disinfected, right? And then you have this root canal treatment. And you can see the root canal treatment done here is very good. You have multiple areas of sealer puff present over there. And I think after a year, there was a failure. And what do you see here? You see a lesion on the lateral aspect of the root. When you see a lesion on the lateral aspect of the root, there are two things that come into your mind. Either there is a root fracture, which is a main cause for this kind of a lesion, or there could be a lateral canal. So, however, when you see multiple puffs like this, don't get too excited about it, like I did once upon a time. It only indicates there could be multiple root fractures or cracks in the tooth. So, this case was a root fracture and we had to extract the tooth. And again, most of us feel good when we have an obturation like this. And if you compare this obturation with tooth number 4-5, this is 4-5, which the arrow is pointing at 4-5, and then you see a 4-4, arrow is pointing at 4-4, and you see 4-5. What is that you see here differently? You see the size of the apical foramen. Now, even if it seemed to be short of apex, it could be the apex locator that is located, and that could be the working length, and your foramen is exiting either on the buccal or on the lingual side. But you look at the size of the GP. Here at 4-5, you see that the apical foramen is nicely opened up, or the size is bigger compared to that of the 4-4. And hence, when the size is big, you have a lot of irrigants getting into that area and disinfecting that region. Whereas when you have a thinner or smaller apical foramen, like this could be 26%, where the apical foramen is still very small. And I know many of you all like to end your obturation or canal preparation with just 26%. And that's a topic by itself. And I'm not a person who will, increase with just 20 unless it's a very, very narrow canal. For me, the comfort instrument is 34%. So I would recommend that you should at least enlarge it to 34% so that all your solutions get into the apical third, which is the critical area. Apical third is a critical area for all our disinfectants should get in there. Only then you will see good healing in the periapical region. This is because most of the lateral canals are present in the apical 1/3. So here, again, if you look at 4-4, you have a lot of space in between the GP and the root canal wall, which again means that it's not a very good obturation. You didn't get a 3-dimensional obturation. And you see that the crown is also leaking on the proximal side. So it's a leaking crown, and there are multiple factors that could have caused failure. But I would still think poor isolation and poor disinfection during the root canal preparation is also a contributing factor. So all these causes might be there, but it is the microbes that actually result cause failure in the root canal. So the microbes that are persisting over there, and the previous dentist has not removed all the microbes, but have got a very good obturation, did a great obturation, a very radio dense obturation, but the microbes are still sitting in there. Now, if there is a visiting endodontist, then your dentist might tell you, you have to finish the root canal in just single sitting, no matter what. And when the tooth is non-vital, that's the best time. The patient does not have pain, and you do your obturation. You don't give time for your antimicrobials to act in the canal, and then you go and obturate. No doubt you'll get a great obturation, but then you failed to remove all the microbes. So microbes play an important role in the success rate of your root canal treatment. So the next question comes, when do we treat it? So the indications for non-surgical endodontic treatment, we are talking about non-surgical and not surgical treatment, are the tooth is symptomatic, irrespective of size of the lesion. Now, we don't have to bother about how big the lesion is. It doesn't matter. Our concern as a dentist or as an endodontist is only inside the canal. Even if the lesion extends to 2 or 3 teeth, but the other teeth are vital, it doesn't matter to us. We need to make sure every microbe is removed from the canal. Second one is asymptomatic teeth, but we see progressive lesion. Every time the patient's coming for a recare appointment, you see the lesions are growing in size, but the patient is asymptomatic. This happens most of the times. Most of the times, these chronic lesions are asymptomatic, but when it is progressive, you need to make sure that you do an retreatment. Tooth that requires placement of fiber, because it's not easy to go in again when there is a patient, when the tooth gets symptomatic. So if you need to place a fiber post or a whatever post of your choice, preferably fiber post, it is better to retreat when the root canal treatment is not done very well. It's better to retreat and then use a fiber post or a tooth that supports the abutment. And the contraindications for non-surgical endodontic treatment is, you see in the first, there is an obstruction. There is a root canal treatment, which was already root canal treated. You can see a small piece of instrument over there in the apical third. Now, when you take a CBCT, sometimes it's very difficult to identify between the instrument and the obturating material. I think Dr. Bharti will be able to tell us how to identify, but otherwise, so in this case, after we removed all the GP from all the canals, this particular canal, that is the mesiolingual canal, or is it a distal lingual canal, still had a piece of instrument which had completely masked with the remaining obturation. When we went there, there was an instrument at the apex. Now, can you remove that instrument? If you can see the instrument through the microscope, you can remove it. If it is in a curvature, then it's challenging. We can still remove, but you end up removing more tooth structure. So you are compromising on the strength of the root too. So in those cases, you can sometimes not do non-surgical endo treatment. You have to opt for surgical endo treatment. We have already covered fracture of tooth, where you'll have a lesion on the lateral aspect of the tooth. Then you have poor bone support. In case the patient does not have good bone support, especially in the lower anteriors, then your root canal treatment, whatever bone loss has occurred because of the infection in the canal, that will regrow or regenerate, but your periodontally, you cannot do much with the root canal treatment. And as I showed you an earlier image, where the obturation is not done in a particular root, but there is no periapical lesion. In those cases, you don't need to go in and do a root canal treatment. Also, in cases where there is apical scar, where there is no infection and there is a surgical, already a periapical surgery has been done, and instead of bone formation, there is a tissue that is formed in that region, which looks like an apical scar, large internal external resorption, and tooth that is not restorable. The root canal is good, but in future the tooth is going to, there's not enough tooth structure, healthy tooth structure to restore the tooth. In those cases, it's best to remove the tooth and place an implant. The next question that came into your mind is, should we remove all the processes? Generally, your patient will tell you that I just got a prosthesis done a year back, and my dentist has told that this has a warranty or guarantee of 10 years, and now you're asking me to remove it. Now, two ways of removing it is either tap it out. There are higher chances of the tooth crown coming along with that, and you're put into more embarrassing situations, or you section it. You lose the crown, but you section it, but you're sure that the tooth structure inside is safe. So you don't know how much tooth structure is there. And if you look at this image in IOPA, and this patient came to us, is 2.5, with severe pain in the tooth. Again, no great periapical lesion over there, but you can see that the obturation is not too great. And in 5s, there's always 2 canals. Most of the times, 90% of the time, there are 2 canals. Very rarely will you have single canal. In this case, 1 canal was missed. It was only 1 single canal that was obturated. And that you can see, even after you do an obturation, when you see there is space between the GP and the root, you have to look for the second canal. It need not be only this tooth, any tooth. When there is space, that means there is another canal. So angulation of X-ray makes a difference. Now, this patient also told me that the food keeps packing in there. And if you look closely at both these radiographs, you can see that there is mesial caries in 2.6. And in a bite wing, which is parallel cone technique, we use parallel cone technique, you can see the same tooth, which is seemingly different. You can see that a bite wing and an IOPA, there is a big difference in the way the tooth looks. Now, when you take this bite wing, you know for sure you need to do many things in this region. You need to restore 2.4, you have to do a distal DO there because the previous dentist has nicked that tooth. You need to do a MO in 2.6, and you need to remove the crown over here and then redo the crown because you have there is a loss of tooth structure in that region. And that is why the patient's been constantly complaining of food lodgement in this region. So angulation of the radiograph, you take a bite wing, you take an IOPA, and you also use your probe to move around the margins of the crown to see if there is any catch. If there is a catch, then you need to make sure you change the crown. And you look at this image here, whenever you have the image of the upper teeth are your Emax crowns, which are cemented with variolink. And you can clearly see here whether there is any marginal integrity is good or not. Whereas if you have a radio opaque crown, then it's difficult for you to see whether the integrity is good because it masks the other side of the crown. So again, you look at these radio opaque crowns, and what's under this crown. When we remove this crown over here, you can see a large lesion, which was not visible in your radiograph. You remove the crown and you see just a large lesion. When you just look at the radiograph, you might think that this is a possibility. You can do a crown again, but if you look at the image there, you hardly have any tooth structure there. If you remove all this decayed tooth structure, you hardly have anything to hold the crown. So in this case, if you had gone ahead and just done a root canal without removing the crown, sooner or later the root canal may be a successful one, but your you will have restorative failure. Your crown would have just crumbled down and you would have had only the roots remaining over there. And the main reason of this failure is your missed canal. So in the first image, you have a missed MB2, which is one of the most common among all missed canals. The second most common is your lower anteriors. And the third one is your premolars. Now, this missed canal is not, this MB2 is not seen only in the 6. You have MB2 even in upper 7s. And it's around 50% of the cases you will have MB2 in upper 7. So you have to look for it. Only if you know that there could be another canal, you will look for it. So if you look at the first image over here, 2-6, you see that the mesial root and the mesial obturation is a very good one. I think they would have enlarged it to 34% or more. But you see that it is moved to one side. It is on one side of the root. So in your following images, you will see where to look for this MB2. And the image on the second is your lower premolar, that is 3-4. And again, you see that the dentist who did the obturation for this, it's not bad at all. You can see that the GP has gone all the way till the root. And you can see the green arrow, that is a 3-4, so much of bone loss that the tooth was almost grade 2 mobility. And if you look at the red arrow, that is 3-5, you can see that there are 2 canals. And I'm sure you can appreciate that you have a large canal bifurcating into 2, so this red arrow indicates 2 canals in 3-5. So whenever you see 2 canals in the adjacent teeth, that means there could have been another canal even in the 4. And in this patient, both sides in the 4-4 and 4-4-4-5, 3-4-3-5 had 2 roots and 2 canals. So it is so important when you do your endo treatment, you need to work under magnification. You cannot do without magnification. And when you work under magnification, it's also mandatory for you to have light in your loop. So do not compromise on magnification. You can start with loops with light. The only thing is you cannot document them. And since, of course, you're getting ergo loops now where you don't have to bend, but if it is not an ergo, you need to slightly bend and look into the teeth. So this is ergo, and the first image is not one. So in ergo, you have to, it's just like a microscope. You look in the front, no bending of head. The lens itself bends down for you so that it is easy. And you can see on the top, you have this little battery for the light. Makes it a wee bit heavier, but it is worth it. It's better than the ones which has wires running from the light to all the way to your pocket. And I think that is more cumbersome, and cordless or wireless ones are much better for your light. And of course, there is no replacement for microscope. Microscope still is the best. And those who have worked with microscope will agree that loops are not a replacement for microscope. Under the microscope, you have a different world of endodontics, which you need to explore and see. And these days, microscopes are not very expensive, and I think it's worth if you plan to do more of endo, I think it's worth the investment. So under the microscope, these are the documentation. You can look at the documentation, how we have documented it. And also, it's easier to work with rubber dam. And like I don't work without rubber dam at all. Every case has to be dammed. And you can see that this is a premolar, and you can see there are 3 canals over here. You have the buccal canal, palatal canal, and the mesial or mid-mesial canal. And this is an upper molar. And routinely we find MB2. Finding MB2 under magnification is no big deal today. It's just that we also find extra canals. It can be an additional distal canal or an additional palatal canal. You find more canals, and sometimes you find a third MB canal, MB3. So even if you leave one canal, it makes a big difference in your success rate. So most of the canals, like I said, most of the failures are due to the missed canals. and most of them are in the maxillary molars, and 93% of the failures in the maxillary molars are due to MB2. And if you look at a cross section of just the mesial root, this is not the cross section of, if you look at only the mesiobuccal root, you will see that there are two canals. And it's not only two canals, and you can see a small little isthmus in between the two canals. Now, some might argue, some might say, I have done so many root canals, but my root canals have never failed. Either your patient's going somewhere else and not come back to you, or it could be that the two canals have merged to form a single canal and you didn't have too many bacteria there in the canal to start with. Now, is it important for us to treat both the canals? The answer is yes. And because of this isthmus. Wherever there is isthmus, there is bacteria. And you need to make sure that you not only clean the two canals, how do we clean this isthmus? So when you instrument, you need to make sure that your instrument is, you brush the instrument towards the possible isthmus present over there, and that will also take your solution in there and disinfect it. So we all know that instruments alone cannot remove all the microbes. Instruments can actually physically remove the contents in the canal, but the microbes are only removed with your disinfecting solution. And of the disinfecting solution, your sodium hypochlorite still stands as the best. So this is a CBCT, and I put this CBCT for you all to understand how is your mesiobuccal root placed in relation to the entire tooth. Okay, so the mesiobuccal root, and if you look at this, it's a magnified form of the same image, and you can see two canals, your mesiobuccal MB1 and MB2. Those are the yellow dots on the mesiobuccal root. And then you have the palatal, that is P. If you draw a line between mesiobuccal and the palatal, because generally mesiobuccal canal is the easiest to find. It's the large canal and it's easiest to find. And where do you find the MB2? You find it slightly mesial to the line drawn between the mesiobuccal root and the palatal root. Never try to go in the same line as the red dotted line. If you try to find the MB2 in the red dotted line, you are definitely going to perforate. Because in that image, you can see if you were on the dotted line, you would have perforated. So it is always there. And you don't have to go looking for it. If you have a good DG16, that's the best instrument for you to locate. You just walk the DG16 probe onto the floor of the canal in this direction where I just told you, and you will find it. And this tracking of MB2 was possible only in 17% of the cases when you don't use a loop. When you use a loop, 62% of the people could find the MB2. While you use a microscope, it jumped to almost 71%. So it is important. This slide shows you that it is important to use magnification in your endo practice. Also, there are some other instruments like this called Mueller burr. Now, Mueller burr is a straight burr which has a very long shank. You can see that it has a very long shank. When you're doing any work under magnification, you need to have a long shank. If you have a short shank, the handpiece head obscures your vision under the microscope or any other, even under your loop. So it's always good for you to have long shank, and that's why we have ultrasonic tips. Ultrasonic tips also, you can see you have a little burr, round burr or a straight diamond or a steel burr, where you just move it on the floor of the pulp chamber to remove any kind of calcified obstructions which will be present in this over this MB2 canals. So this is an image where you can see that I have opened for a root canal treatment. I've done an axis opening, and I've found the three canals. First thing you need to do is find the easier one. Clear your chamber nicely. You can use ultrasonic to clear the chamber. You can also use your slow speed burrs And then you can see where exactly I have used my number 10 K file. That's exactly where your MB2 is. And we enlarged it. So this figure is not so clear, but that's how we have enlarged the MB2. Now, should we remove GP from all the canals? Okay. So here you see that in the first image, again, you see that the root canal is very good, but there is periapical lesion. And do I remove GP even from the distal root? And you look at this image. The difference between these two is there is in the second image, you can see there is communication between one root and the other root canal. So then the microbes have a chance to move around and cause failure. So one canal will cause microbes in one canal can cause failure of the other canal. Whereas in the first image, there is a proper obturation and there is a proper seal at the orifice level itself. So the chances of microbes going into the adjacent root or the root canal is very, very less. So you don't need to remove all the GP from both the canals if the seal is very good. Next, we come to how to treat. Okay. Dr. Bharti can just stop me. We don't have much, so I will just run through this. Okay. Now, our main goal is to reach the foramen. If a patient comes to me and he or she will ask me, how do you think this is going to be successful? I tell them, if I can reach the apex, I will tell you that this tooth can be saved. So remove all the filling materials because you see more of the biofilms that contain bacteria. So our aim is to reach the foramen, remove all the filling materials that are present. Sometimes you reach the foramen, but if you leave the filling material, even that will cause failure, okay? It's not just reaching the foramen. We need to remove all the filling material, eliminate the microbial load, or if you cannot eliminate all the microbes, like in the lateral canals or accessory canals, you starve the microbes by just sealing them. You don't give them any food and they will die a natural death. So seal all the portals of communication or isolate the canal from the surrounding environment. That's how you seal them. So you have rotary instruments to remove the GP. You have hand files or you have solvents. Okay. So options in rotary, plenty. You don't know what to choose. You have so many of them. Now, when you look at these instruments, you need to see what is the safest of all, especially in curved canals. Will these instruments that I see on this place over here, will they cause straightening of the canal? Or the design is such that instead of removing the filling material towards the orifice, will they push the filling material into the apex? Or if they're very stiff, will they cause apical cracks and cause more iatrogenic errors? So you need to choose what is best for you. So we need to avoid very stiff instruments. Like you see over here, you have, this is a patient who came in 2017 and you see broken instruments, one broken instrument at the curve, another broken instrument in the distal root, again at the curvature. So there is a cyclic fatigue failure over here. Now, if I'm going to use my instrument, I'm trying to make an axis and I'm going to use instrument. And if it's a stiff instrument, I'm going to land up making it bigger and create more ledge like what you see here. Yeah. So we tried to remove this instrument over here and I could not remove the instrument. So I decided to obturate. I bypassed it and I obturated it. I could not remove even the distal, both the ones in the, but you can see that my sealer is gone beyond the apex, which I think that I have cleaned the canal, and only when the canal is very clean, then your sealer goes beyond the apex. If there is debris, it will not go beyond the apex. So what I like to use is high flex remover. So this has more like, it is a flexible instrument. It's not very stiff and it is a 7% you have only one file in that. So it respects the anatomy because of its curve. You can see that on the right side, how I have curved the instrument, and you can see that you can curve the instrument or bend the instrument with your finger itself. And it has a non-cutting tip, so it's not very aggressive. It's not going to make any ledges over there. And it respects the anatomy. And you get only one size, that is the 30 size and 7% taper. Now, these instruments come in two lengths, 19 mm and 23 mm. It's not 21 and 25. It is 2 mm short of the standard instrument length. That's because what it says is you have to stop using the rotary instrument 2 mm short of your working length. The remaining 2 mm has to be, the GP in the remaining 2 mm has to be removed with the hand instrument, because those are very delicate area. So this is how you use them: 800 RPM, 2.5 Newton centimeter torque, and you have to slowly use, just like your rotary instrument, brush them out so that it grabs, because it's the, you can see that it's just like your H file. So it has a positive rake and it can remove all the GP from there. And the good thing over here is no solvent is required. You don't have to use a solvent here. You can only use the instrument. Now, why is it not good to use a solvent? I'll come to it. So you have K file, you have H file. K file, you penetrate in and create a pathway for the H file. You don't use a H file to create a pathway. You create a pathway with K file. So K file and H file. Finally, you can remove the GP with the H file because it has a positive rake. So if you don't have a rotary instrument, this is how you have to use. You can also make a small little, staging, or use your probably your GG drills, which is also a rotary, but it's not like your conventional rotary instrument. And then you go with your K file and remove everything. Of course, here we have used a rotary till then, but there are sometimes your GP can go beyond the apex. It can be pushed slightly beyond the apex if their obturation is not very good. Yeah. So in those times, you can again use a H file, slowly go in there, and you try to grab it and remove the GP. So solvents most often used is extract of orange. We don't use xylene and other materials now. But the problem with them is these form a small little ball of soft material that can also penetrate into all your dentinal tubules and block it. And that is very difficult to remove. The softened GP is more difficult to remove compared to a GP in a solid form. So I have stopped using GP solvent. Very rarely will I use GP solvent, and it's easier to remove with the rotary file. Now, once your GP, as you're removing the GP, this is the only time I use hydrogen peroxide. Otherwise, in my regular routine endo treatment, I don't use hydrogen peroxide. But when you use hydrogen peroxide along with sodium hypochlorite, it gives you that effervescence because of the nascent oxygen that is formed, and it will push all the debris towards the orifice. And also you can use the EDTA to open up the dentinal tubules, and that will give you a better three-dimensional obturation. And what I like to use is your endodontic, ultrasonification. That is, you place your solution and use your ultrasonic file to agitate the solution so that it gets into all the lateral canals and gives you a three-dimensional disinfection. Apex locator, yes, you need to use the apex locator. Most of the times it might give you a right reading, but sometimes you may not get the true reading. And at that time, your CBCT helps. And I always recommend a CBCT when you're doing a retreatment. It's always good for you to have a reference with your CBCT, and they give you a very, very good reading, and they will tell you what is wrong and where do we need to look for GP. Even if there is an instrument, they will tell you where exactly, which canal there is an instrument, what is the problem, what is the cause of this retreatment. So it's always good to have a CBCT. Also, in one of my cases, the MB2 was way below, the opening of that MB2 was way below the floor of the chamber. And I took help from Dr. Vinod at that point to locate the orifice of the MB2. And it was 3 millimeters below my floor of the chamber. I had to go into the root. And if I didn't have that reference, it would have resulted in perforation. So always have CBCT as your reference for retreatment. So first appointment, we remove the GP and I give what is called open dressing. Open dressing is not what you all think, where there is no access filling at all. Open dressing for me is no intracanal medicament in that particular root canal. You still close the access opening, but your canals are open for drainage. So you don't want saliva to get into the root canal and complicate your root canal, resulting in failure. You want to close the or access opening, but you keep the canals open. And in the second appointment, I again clean it up nicely. Now I'm giving a dressing with calcium hydroxide. And that is close dressing for me. And in the third appointment, I leave it for a week, make sure that the patient is totally asymptomatic and not under any medication. And that's when we obturate. So before we wind up, and I would like to just wind up with just 5 cases of mine. And mine is more of a retreatment center, more than the regular. I get more of failed cases. So this is the case which I showed you. I don't have a very good pre-op, but you can appreciate that there is a lot of bone loss in the periodontal area. As I told you, it's a grade 2. And you can see here, even on the left side, all the root canals, whoever did the root canal, one dentist who did the root canal, all the root canals are failing. You have 4, 3, 4, you have 3, 3, 4, 3 and 4, 5 failing. You have 1, 2 failing. So all the root canals are failing. So that means there is an issue with their protocols of treatment, which needs to be changed. So we removed all the contents of the canal. And the angulation doesn't show you the second canal, but the obturation shows you the second canal. It's the angulation of the radiograph. And you can still see good bone loss. This is sequential. And then the patient comes for a follow-up. And 7 months later, the tooth is completely firm. So in this case, when I don't know, I'm not sure if the tooth is going to be firm, then I only give them a temporary crown. I don't give them a permanent crown. I give them a temporary crown. This is a case 2. So you can see here, it's a tooth number 4-6. So there is a failure over here. And then we treat the patient. After we treat, you can see that there is a good amount of bone loss in the mesial root and in the cervical region. And you can see from his OPG that he's a periodontally compromised patient. And you can see after in the April 2023, from July 2021 to 23, that's when he came back. And that's what he came because of some other problem in his mouth. And we took this radiograph and you can see a good bone formation there, right? Good bone formation, especially interradicular. You see that there is good bone formation. This is a case 3, which I showed you again. Very good obturation. I really liked the obturation. But then they came back and you can see that there was a small little, in the mesial root, an extra canal that was going in there that we obturated. And you can see the bone formation there, right? So this is one of my favorite cases. the bone formed here, then you can see caries also on the 4-7. So this is a fourth case, which I showed you. I showed you my obturation too. And 1 year later, almost 1 year, you can see a good bone formation in the periradicular region, in spite of us not removing the instrument in both the canals. We just bypassed and obturated. We've just bypassed, disinfected, used a lot of sodium hypochlorite to disinfect completely. And this is what we see. There is a follow-up after that also. The tooth is very, very stable, though I don't have it over here. This is my last case. So this is a patient. You can see in 4-6, there is an instrument breakage, but her problem was in 4-7. And whoever did the root canal, it was an intention that is what I heard from the patient, that it was an intentional root canal that was done to facilitate crown in these teeth. So intentional root canal failed after 1 year. And this is after 1 year, you can see in 4-7 that the bone formation is very good. So especially in the interradicular, you see the mesial aspect of the root, you can see a good bone formation over there. So what did we do? We didn't go beyond the apex at all. We didn't touch the periodontal tissue, but still we obtained good bone formation. Okay. So with that, I thank you for your attention. And thank you for taking out time from your busy schedule and attending this program.
Thank you, ma'am. Thank you from our end also. Ma'am, can we have answers for a few questions, ma'am?
Yes, yes.
Yeah, Dr. Rupa is asking that when previous obturation is size 20 to 25, 4%, can we still use high flex remover?
Yes, you can remove, because we are not going to remove it all the way till the apex. 20, I wouldn't recommend. It's always better for you to enlarge it more than that. So 20, what I mean is, even if you use a high flex remover in 20, don't worry that it's going to be larger. 20 is not a size for you to obturate, but yes, high flex remover will remove from both 20 and 25 size obturated canals.
Okay. And Dr. Sushrita is asking, how often do you advise CBCT before a retreatment case?
Every case in molars and premolars. Anterior, not so much, but if you have access, it's very good. You see canines, especially canines, you have more than 2 canals. Though it is I think the incidence is just 3%, but in my practice, I've got multiple cases with 2 canals, both in maxillary and mandibular. So if a good RCT fails, you must take a CBCT.
Okay, thank you, ma'am. Dr. Srividya Bhatt is asking, how do we do retreatment if it is done with bioceramic sealer?
If you're using bioceramic sealer, but you still have GP, right? So you can still access GP. And with your rotary instrument, you can remove the bioceramic sealer to a great extent. But if your solvents will not be able to dissolve. So if you're going to use, if it is an MTA obturated canal, then you cannot use it.
Okay. Dr. Abhishek is asking, ma'am, is there any expiry date for a root canal treated tooth?
No expiry date. Expiry date of the patient is the expiry date of the root canal.
Dr. Akhtar is asking, which type of sealer used in retreatment?
Which kind of sealer?
Is used in retreatment cases.
You can use any sealer. What you do is so important, and how you seal is very important. Some like to use zinc oxyreginol. I don't use zinc oxyreginol. I like Gutaflow, which has GP powder in it, and it has a Rico seal. Or you can use even H+, or you can use any bioceramic sealer also. If you're using bioceramic sealer or Gutaflow, you can do a single cone technique. If you're using any other, then you need to do lateral compaction or vertical compaction.
Okay, thank you, ma'am. Next question. Is MTA plug mandatory if apical diameter is over 50? And how do we place MTA plug? Dr. Rashmi is asking this.
What is that?
Is MTA plug mandatory if apical diameter is over 50? And how do we place MTA plug?
Over 50, we get GP till 80, isn't it? We can use even up to 80 GP if you're getting a good tuck back. And MTA plug, how do we use it? You have MTA putty now, you can use putty or you can mix it with the powder liquid, and you have MTA carriers, which you can place it in the canal and you can push it with a plugger, appropriate size plugger, which you would have already selected before using it, which will fit 3 millimeters or 2 millimeters above the short of the apex working length. You can also use a little cotton, wet, moist cotton, sterile cotton, and use that to push the MTA to the apex, and you have to keep taking radiographs.
Okay. Ma'am, Dr. Rupa is asking if there is fractured rotary instrument from mid-third to apex, can such cases be solved?
Yes, as long as you can see the head of the instrument, you have to try and remove it. It's only in the curvatures that you may not be. For you to retrieve any instrument, you need to see the instrument. And you can see that under microscope and you can retrieve it.
Are there any more questions, participants?
What about seal apex? Somebody is asking. Seal apex, you mean
Yes,
is it, you're talking about the root canal sealer, I'm guessing? Seal apex has both calcium hydroxide and resin in it. And you can use seal apex too, no problem. It's a resin based and has calcium hydroxide. What is the question?
Ma'am, Dr. Ashwini is asking that question only, ma'am? Or next?
No, any question, I'm okay.
If there is a large lesion, radiolucency around mesial root of maxillary 6, almost breaching the sinus, how do we treat that case?
The size of the lesion doesn't matter to us. You still treat it like there is no lesion. And you will see, the body will take care of it. We don't have to do anything.
Okay. Dr. John is asking, is there any such case wherein we are not able to remove the filling material fully, and how do we go about in such cases?
If you're not able to remove, you're compromising on the prognosis. And only if you remove it completely, you will, now let me tell you, sometimes even after you remove, if you don't remove it completely, that means apical 1/3 of your bacteria is still there. If you cannot remove it, then you need to do surgical removal. Surgically, you have to remove that area. Sometimes you might have a bone regeneration, then over a period of time, you might see the bone loss of bone because of that existing 1 millimeter also. So you have to make sure that everything is removed. Your prognosis depends on removal of all the materials and your patency, or how well you can go all the way till the apex and disinfect it.
Okay. Thank you, ma'am. Dr. Akhtar is asking, can we do retreatment in single sitting?
No. No.
Yeah.
Because you have more resistant bacteria, I wouldn't recommend. It's easy for you to do single sitting RCT is anybody can do single sitting RCT. It's not what happens 6 months, 1 year after single sitting RCT is what you need to see.
Dr. Vinod sir wants to know that little about endo guides, ma'am, if you can enlighten on this.
Endo guides. I have not used them personally, the endo guide. When I have a difficult case, I'm going to go back to Vinod and ask him to make fun for me. But I believe those who have used it swear by it. I was fortunate enough to share the podium with one of the speakers in Style Italiano, and he was doing a lot of work on EndoGuide and how he was treating complex root canals that I have not seen in my 30 years of practice, but I have seen him using EndoGuide and getting into a lot of intricate areas of the thing. So I think with CBCT, with the help of CBCT and your 3D printing, they can do a lot of good things with EndoGuide. And I think it's worth, it's good to try them. Till now, I didn't need, but I think it's good.
Dr. Rashmi is asking, what are the other intracanal medicaments used in retreatment cases other than calcium hydroxide?
Calcium hydroxide and chlorhexidine can be used. Chlorhexidine gel also can be used. Definitely no pharmacrosol, if that is what some of them are using. That's an outdated intracanal medicament. It's calcium hydroxide or chlorhexidine gel.
If patient is having swelling due to infection of the tooth, can we do RCT in single sitting? Dr. Lukman is asking.
I wouldn't recommend. If there is swelling, you need to give time for it to drain if there is pus over there. So I don't think it's recommended. I wouldn't recommend. I wouldn't do a root canal when there is obturation or a single visit RCT in patients who have swelling. I think it's one of the requirement. It should not be there. Patient should be asymptomatic, no swelling. Only if there is sinus drainage, you can, but not recommended.
Dr. Shanmukha is asking, can 1:1 crown root ratio saved for prosthetic support?
1:1. It doesn't survive for long. 1:1 ratio. I don't think the prognosis is good in 1:1.
Dr. Sanath is asking, if the tooth has post and core treated and there is lesion below the tooth, can we retreat the tooth?
So what kind of post are we talking about? If it is a screw post, and if it is sealed with GIC, you can use ultrasonics to shake it off, and you can remove the screw post by moving it anti-clockwise. If it is a fiber post, you need to make a little drill in the middle of the fiber post, and then you use your rotary instrument to crack the fiber post, and you can still access it, because generally the fiber posts are not going all the way till the 2/3 of the canal and all that. It generally placed only 5 millimeters into the 5 to 7 millimeters into the canal. If it is a cast post, which is it is more like a friction grip, then you need to remove the tooth structure around it, relieve it, and then slowly tease it with your artery forceps. You can remove it. What challenge you will have in these cemented posts is, if there is a lot of space between the post and the GP, and that area is filled with GIC, that's the challenge you'll have to go. You will probably remove the post, but to go beyond the GIC might be a little more task. So you need to see one of your ultrasonic tips that are there, a little stronger tip. You need to see if you can debond the GIC that is there at the base of the post.
Ma'am, Dr. Sushrita is asking, do you use double antibiotic paste as an intracanal medicament?
Yeah, no, I don't use. For me, I don't even use chlorhexidine. For me, all these results that you have seen, I have got it only with calcium hydroxide dressing. Cases where I have just placed calcium hydroxide dressing and not even completed obturation, and for some reason, if the patient has not come back, And in 3 months, we see a big change in the periradicular. The lesions already disappearing, and the bone is forming. So we do see that such cases.
Wow. Ma'am, Dr. Lukman is asking how much of sodium hypochlorite can be used per sitting for root canal, and she's also asking which is the good textbook for endodontic purpose.
Yeah, I'm out of academics for a long time now. Okay, I am 2013, I've left academics. We're 11 years now. So I think any textbook, if you read them thoroughly, I can't tell you to read Engel and Cohen, but Cohen is a good book, I think. And see, more than the textbooks, I think you should look into articles. Yeah, you pick up a review article on root canal irrigants. You will get plenty on the internet. So you look for review articles. Review articles will be more updated. It's since if you are a practitioner, you have good review articles. And I think you should refer review articles for how much of sodium hypochlorite is used. To be frank, I don't use too much. The volume of your root canal is a very, very tiny one. But my advice to all of you all is don't dilute the sodium hypochlorite. If you need, I use 5.2%. If you need 3%, don't dilute 5.2%. You are not going to do a good job at that. You get 3%. You get 2.5%. But don't dilute your sodium hypochlorite. So sodium hypochlorite is one of the cheapest ingredient in your entire root canal armamentarium, and do not dilute it. And nothing is going to happen. Don't think about those horrendous pictures in the textbook that with, those root canal is a closed system. Make sure that your syringe is not bound to the root canal wall. Let it be loose so that your sodium hypochlorite backflows into the orifice. Only when you bind it, it will go beyond the apex. So don't hesitate to use full concentration. So I will use 5.2%, but for a root canal, I might not even use 2 ml. I'm not even using entire 2 ml for the entire 3 or 4 canals. I'm using little, but I'm using more often. And that is after every use of instrument, I will flush it. So the flushing again, if you use more, you're only wasting it. You're only getting into your suction. So use more often, but more often, but full concentration of sodium hypochlorite, 5.2 or 3.3% or 2.5%. Okay. I hope I answered your question.
Yes, ma'am. Dr. Suma is asking just plain calcium hydroxide or calcium hydroxide with iodoform like Metapex.
Plain will do. Plain will do. No harm in using. Now, the two difference with iodoform is more, it's not water soluble. And while your calcium hydroxide is water soluble, it's easy for you to remove it also. So even just calcium hydroxide will do. Iodoform will add on to your disinfection, but patients don't like the taste, that little smell that comes out even from the canal, even if you seal it well. So calcium hydroxide is good enough.
Dr. Ramya is asking that do thin crack lines or craze lines across the roots of endodontically treated teeth affect the success of RC treatment?
It's a good question. Craze lines, very difficult to find. Crack lines may be present. And I don't know, Bharti, you should tell me whether it is easy to find craze and crack lines in the CBCT. I do get some of the your report saying that there is craze lines and crack lines. I would think if I see that your CBCT has mentioned about craze lines and crack lines, I will straight away go for a bioceramic sealer, and assuming that my single cone and bioceramic sealer will seal those cracks and help me keep the tooth for a longer time. But it's very difficult for you to see crack lines is visible under the microscope. Craze lines in the root, I'm not too sure. But if there is a mention, like I said, please use a bioceramic sealer. That will help. Avoid any sealer that expands, like your Eco expands, and your bioceramic expands to some extent, not too much, but those that shrink do not have. Bioceramic is still a very good sealer, but it doesn't shrink as much. So don't use sealers that will expand. That will increase the chances of fracture.
Thank you, ma'am. Are there any more questions, participants? Dr. John is asking, is there any such case wherein you are not able to remove the filling material fully? And how do we go about in such cases?
So it's good for you to take a consent form from the patient and tell them that there is a challenge or block near the area. So you still go ahead and do a good obturation, wait and watch, and you see there is a lesion, then you approach surgically. You go in surgically, remove that 2 millimeters or whatever amount that you are not being able, or there might be a ledge that is created by your previous dentist and you cannot bypass it. Now, whatever we spoke about is a non-surgical way of treating retreatment. You can always go for surgical. So if you have a good surgeon, or if you are a good surgeon yourself, you can open it up, resect the root and do a retrofilling with MTA or biodentin.
One of the doctors is asking that, is it good to do coronal sealing soon after the obturation, ma'am?
Yes, of course. Yes, you can do coronal seal. You have to do. You should do it immediately after obturation.
Dr. Ramya is asking, does partially filled canal with traceable 2 to 3 mm traceable canal apical to obturation affect the success of RC?
Yes, it does, because it's a 2 to 3 millimeters of your apex itself is very critical. All our enlarging the canal, disinfecting is all to reach that 2 to 3 millimeters. And if you fail to reach that 2 to 3 millimeters of the apical 2 to 3 millimeters, then you failed in your root canal. So you need all the lateral canals. Apical delta is all about that. You have a lot of lateral canals in the apical 1/3 of the canal. So it's important for us to see whatever is your working length. Your 1/3 apical 1/3 measures to 3 to 4 millimeters of the root. So your root is only 9 millimeters or maybe 11 millimeters. So that 3 millimeters is a very, very critical part. It will fail. If you have not obturated an infected tooth, it will fail eventually.
Do you recommend apicectomy in failed RC of maxillary 6? Dr. Ashwini is asking.
Maxillary 6.
Do you recommend apicectomy in failed re-endo of maxillary 6?
Which root of maxillary 6? Palatal is more difficult to approach, but it's easier to retreat. When we do apicectomy or apical surgery of buccal roots, it's easier to access, and you're removing 3 millimeters. So it shouldn't matter. You can reach it, because if there is in a failed root canal, generally there is a lesion. So it's easier to reflect and resect the root. And it's easier to place a retrofilling too. I would recommend. We have done a lot. We have done cases with apical surgery in maxillary teeth.
Thank you, ma'am. Dr. Akhtar is asking, throw some light on use of ultrasonic activation.
Ultrasonic, you place the sodium hypochlorite or any of your disinfecting solution. Here it's sodium hypochlorite. You use the ultrasonic file at minimal frequency. Make sure that the file doesn't bind, and you use it for 20 to 30 seconds in each canal.
Dr. Srividya is asking, which is the best GP cutter or obturation pen?
GP cutter? I use the same, you have in Element System, or you have, even in Woodpecker, you have a condenser, right? The plugger, heated plugger. It's not with the fire and the burnisher. It's a heated plugger you get in woodpecker or element system or any Calumet system. You use those pluggers to remove the GP. I think that's what she meant, GP cutter. Yeah.
Thank you, ma'am. Dr. Lukman is asking, she got RC done with her 3-6. After a year, it was painful. So did CBCT. There is a crack line, but again, after taking medication, the pain is subsided. Now she's asking that now I am with that tooth since 2 years. My question is, will I last more? Will that, I think she means to say, will that tooth last more?
Well, you took a course of antibiotics. You got a temporary relief. It's not, if you have not done anything inside the canal, then it's just a temporary relief. It's going to come up again and you have to do a retreatment. And if you think that it is not, then it was not a pain due to your endo cause or due to your root canal. It could be your perio reason why you had this problem. If it is due to endo, then you will definitely see, even if you take antibiotics is not going to get into the root canal. There's no blood supply to the root canal, right? So you taking antibiotic in a retreatment case, you should not think that your infection inside the canal is going to get cured. It's not going to. It's only periapical. Wherever the blood supply is there, you will have your antibodies there. You will not get into your root canal because there's no blood supply.
Thank you, ma'am. Thank you so much. I hope all are done with their questions. I would like to thank ma'am for sharing her great expertise with us and for taking out her time to share her knowledge. Thank you so much, ma'am. And I hope ma'am's presentation was very much beneficial to all our attendees. Thank you, ma'am, once again.
Thank you, Bharti, and I wish you and your team all the best. And I hope you have many more of these programs where people can just stay at home and listen to you and enhance their knowledge. Thank you.
Thank you so much.
Thank you.
That. And I have a note for all the participants. You will be receiving a mail. Please follow that, and you all will be going to receive an e-certificate for attending this session. Thank you all once again. Thank you, ma'am.